Okay, so moving on, we're on part 2 now. Now that we kind of understand the taxonomy of modes, like what those names mean, what mode do we start our patient on? Well, the book answer is any mode that involves mandatory breaths. PCAC, PCSIMV, VCAC, VCSIMV, even PRVC is acceptable, but you will probably never see that come up on the TMC, but it would be an acceptable answer. Really, the real world answer is volume control, AC. If somebody just got intubated, right, let's think about it. You need to establish a baseline on them. You have no idea what their blood gas will look like on the vent, and you have no idea what their lung compliance and resistance looks like before they're on the vent as well. I personally use a ton of pressure control, and I think it's ideal for most but not all patients, but I have to get a baseline first. Now, yeah, once again, if you go by the book, it says that you can start them on pressure control with an inspiratory pressure less than 35, but really, you should be setting based off of their plateau pressure on volume control so you have a good idea of where to start at. Guessing with inspiratory pressure when this is a new patient to you and they're just now intubated, it's not a good idea. Now we've established that for the test, you can do any mode you want, and in the real world, you should probably stick with volume control. So what are acceptable starting settings? Well, going by the book, you should have a respiratory rate somewhere between 10 and 20. Your tidal volume should be 5 to 10 mils per kilo IBW, except for special cases such as lung protective ventilation being 6 to 8 mils per kilo, and status asthmaticus being as low as 4 mils per kilo. And if you're in pressure control, your inspiratory pressure should be less than or equal to 35, or based on your previous P-plat from volume control. FiO2 should be 40 to 60% if their previous FiO2 was unknown or at the same as their previous FiO2. PEEP should be set at 2 to 6 centimeters of water, or whatever they were previously on if they were on CPAP. Now, remember, that's the book answer. And the book really doesn't mention how to set things like trigger variable, I time, IDE ratio, or flow. Now, in reality, your starting PEEP should probably be more like 5 to 8, depending on patient situation. Starting FiO2 should be 100%, which you can quickly and aggressively titrate down if a patient is doing well. And inspiratory pressure should ideally be set at 14 or lower if you're not going to go off of a P-plat, and you should do that in order to minimize the driving pressure. Now, I personally like to start at the higher end and titrate down if able, especially if the patient is being intubated for some kind of respiratory failure. If it's airway protection or something like that, it's a little different. But if we're looking at like a refractory hypoxemia, right, the patient's got pneumonia or something, I'm going to start more aggressively. I'll typically start at like a rate of 18 to 20, tidal volume like 7 to 8 mils per kilo, PEEP of 5, 100%. The philosophy is we can always titrate down as tolerated, but I'd rather overshoot the starting amount of support I'm giving than undershoot it. Now, I always like to put the patient on a flow trigger. As I said before, it's easier for the patient. Usually I'm going to set around 2 to 5. If there's dyssynchrony and missed triggers, which I'll talk about in the next part, then you need to decrease the sensitivity. Now for I time, I'm going to set around 0.8 to 0.9 seconds in volume control and around 1.2 to 1.4 in pressure control, but I'm going to adjust it based on the flow waveform and on patient comfort. Now, not all ventilators will give you an I time and volume control. Let me switch back to the Hamilton. So let me go into the Hamilton. Let me just pick their VCAC, okay? This is what we're going to pick. And now here are the settings. Not all ventilators and volume control are going to give you an I time. Some will give you what the flow is going to be, right? Some might even give you like an IDE ratio or something like that. If it's flow, I'll try to set it fairly high, probably around 40 to 60, so we don't flow starve the patient. And this will give a shorter I time, but we like short I times in volume control. IDE ratio, I really don't worry about. Yes, I know the book will say keep it 1 to 2 or 1 to 3 unless they're obstructive. But what's really important is making sure that your flow waveform is returning to baseline, not the IDE ratio. I will happily put somebody on pressure control with an I time of 1.6 and IDE of 1 to 1.5 if their physiology likes it. Okay, so for this purpose, let's go ahead and put in some vent settings. Here we are. Of course, on the actual Hamilton, you're going to use the knob, but I'm just here clicking away. Once again, let's go with some regular aggressive-ish starting settings. Let's say 500 gives them like 7 mils per kilo. You've got PEEP of 5. You've got 100%, FiO2, flow trigger. That's okay, but I'm going to set it lower to like 2. This can also do pressure trigger as well, right? You can go all the way up to 15. Yikes. Jesus. And this has some kind of intelligent trigger as well. I don't know exactly what that is. Maybe it's some kind of like, like the neuro trigger or something like that. I have no idea. You also set here flow pattern. So square is kind of traditional. Descending is really optimal for the most part. And then you have other ones as well. Oh, this is descending with a little drop off. This is just straight up descending. That's sinusoidal. We're going to keep it a square. Go old school. In reality flow pattern, I'm not going to get too much into that. It's kind of a complex thing. And in volume control, not really a big deal. Honestly, not a huge deal. Know that it does make a little bit of a difference, but Now we're going to look at our alarms. This one actually doesn't tell you based on your eye time what your flow rate is, which is kind of strange. Usually they tell you that, but whatever. Now let's look at alarms. Once again, every ventilator is going to have slightly different alarm settings, okay? But going off the book, what you want is you want your peak pressure, your high pressure to be 10 above your peak pressure. You want your low pressure to be 10 below the peak pressure. You want your low tidal volume alarm 100 mLs below your exhale tidal volume, and high minute ventilation 10% above exhaled minute vent, low minute ventilation 10% below exhaled minute vent. And that's kind of the book way to do it. In the real world, I would set the minute vent alarms a little bit looser than that, probably. And I'd set the peak pressure alarm around 40 to 45, generally. So like right here, honestly, I'm fine with this. Once again, not going by the book, but just going by me looking at that. Expiratory 9.5, that's actually kind of low. And honestly, if I'm gonna rate it 18, 5.0, I mean, do the math, that's already 9. So like 9.5 is crazy. Even by book, we would be setting it like 10. But for me, I'm gonna set it like 15. A low of 4 is fine. Respiratory rate. A low rate alarm in a mode with a mandatory rate is hilarious. What are we doing? High rate 40, I'm fine with that. Tidal volume, I'm gonna set this fairly high, probably like at least 1,000 for the high. Low, I'm gonna set it to probably like 200-ish. Apnea time, once again, on a mandatory mode is crazy. End tidal, that's 60 is crazy high, and 30 is really, I don't know. I'd be setting that to like 20, honestly. I don't know what's with these defaults. It's crazy. So that's pretty much it for alarms. That's how we're going to set it. Now, once again, the minute vent, that kind of stuff, you kind of can't really set that even by the book until you actually start them on the ventilator. So let's go ahead and do that.